Hello all, I'm Dr. Ayalew. I'm an assistant professor of emergency medicine. So in today's update, we are going to discuss about cardiac arrest and resuscitation during COVID. So this recommendation is based on the American Heart Association 2020 update. So at the end of the session, you will be able to approach and manage patients with cardiac arrest with COVID or without COVID safely. So as you know, COVID is affecting worldwide. So worldwide reports show that 12 to 19% of COVID patients require hospital admission. From these, 3 to 5% become critically ill. So when you see the causes of cardiac arrest during cardiac arrest, the first one is, and the commonest one, is hypoxic respiratory failure, which is mainly because of acute respiratory distress syndrome. And the other is myocardial injury. And the last one, ventricular arrhythmia and shock. In addition, there is also caused by drugs like hydrochloroquine and azithromycin. As you know, these drugs cause QT prolongation. And the other is infection. So infections from different causes can lead to cardiac arrest in such patients. So as you know, healthcare workers are highly at risk for COVID. So this is mainly because of the worldwide shortage of PPE, personal protective equipment, and resuscitation by itself has greater risk for healthcare workers. So why resuscitation and COVID are correlated? One, CPR involves performing with aerosolizing generating procedures. So this is mainly because of chest compression, positive pressure ventilation, and also establishment of an advanced airway will lead to the virus to be released to the air. To bring these procedures, the virus can be released to the air with a half-life of approximately 1 hour and can be inhaled by the nearby supportive staffs and also colleagues. And the second one is resuscitation first require numerous providers to work in a close proximity to one another in the patient. And high stress management condition during resuscitation, which require immediate need of a patient's resuscitation, may result in lapse in infection control practice. Okay? So what do you do? What should be done in this condition? So you have to balance the interest of providing timely and high quality care and high quality resuscitation with protection of the rescuer. Okay? So we have to simultaneously protect the rescuer and you have to provide timely and high quality resuscitation. So let's see the general principles of resuscitation in suspected and confirmed COVID-19 case. So there are 3 main principles. The first one is you have to reduce provider exposure to COVID-19. The second one is prioritize oxygenation and ventilation strategies with lower aerosolizing risk. And the third one is consider the appropriateness of starting and continuing resuscitation. So these general principles are from American Heart Association. So they developed 14 strategies to implement this. And the first one, you have to reduce provider exposure to COVID-19 with, before entering to the scene, all rescues should be done with proper PPE and limit the personnel in the room. Okay. And if possible, if it's available, you can replace manual chest compression with mechanical CPR device. And there should be clear communication about the COVID status to a new provider before their arrival or during transfer of those COVID-19 patients to another settings. And the second one is prioritizing oxygenation and ventilation strategy with lower aerosolizing risk. So you have to attach viral filters, and it should be secure to the ventilator and also to tubes. Patients in cardiac arrest should be intubated with a cuffed tube at the earliest feasible opportunity. and also minimize the likelihood of failed intubation. So this can be done by intubating by experienced intubator, and also you can pause chest compression to intubate. If available, you can also use video laryngoscopy. The third one is consideration of appropriateness of the starting and continuation of the resuscitation. So this is based on the goal of care of the patient. Okay, so before patient condition deteriorate, early anticipation and discussion with the caregivers and also the patients on the increased level of care should be done. And the health system should institute policies to guide frontline providers in determining the appropriateness of starting and terminating CPR. There is insufficient data to support extracorporeal cardiopulmonary resuscitation for COVID-19 patients till now. So now let's see the algorithm changes with key differences. So for patient COVID-19 negative patients or not suspected, cardiac arrest resuscitation should proceed according to the standard algorithms. But for COVID-19 positive, confirmed or suspected patients, let's see the BLS algorithm first, and then we'll see the ACLS algorithm. So the first one is verify scene safety. Okay, so as you know, the first is scene safety, and then proper donning of PP, and you should limit personnel, which is followed by the proper BLS algorithm, check your responsiveness, get for help, get AED, check for pulse and breathing. If there is no pulse, no breathing, you will start CPR. If the patient has pulse but no breathing, you can provide rescue breathing using bag mask device with a filter and tight seal. But you can't use mouth to mouth or mouth to pocket mask. If the patient doesn't have pulse, doesn't have breathing, you start CPR with surge compression and 2 breaths. If you have bag mask device with a filter and tight seal, you can use it. Otherwise, you have to do continuous compression with passive oxygenation using face mask. When the AED arrives, you can check the rhythm and you can follow subsequently. So the main changes here, you have to verify scene safety with donning and limiting personnel. And while you are using bag mask device, there should be a filter and tight seal of the bag mask. While you are doing CPR, if you get bag mask device, you can use it with proper tight seal and filter. Otherwise, you can just do continuous compression with passive oxygenation using face mask. So now let's see the ACLS cardiac arrest algorithm. And the first thing is you have to do properly PP, limit personnel, and also consider the resuscitation appropriateness. Then you start CPR, give oxygen, you have to limit aerosolization, touch monitor, and you have to be prepared to intubate. So you will decide based on the rhythm whether it's shockable or non-shockable. After you should decide that, you have to prioritize intubation. So you can pause the chest compression for intubation. If intubation delayed, you can consider supraglottic device, and you can connect to ventilator with filter. Then you will follow the CPR algorithm, you check the rhythm. If it's shockable, you shock, and you continue the medications accordingly. When you are placing an advanced airway, you have to minimize closed circuit disconnection and use intubation with highest likelihood of first pass success. And you can also consider video laryngoscopies if available. So the major changes are here. So donning, proper donning, limit personnel, consider resuscitation appropriateness, start CPR with limiting aerosolization, attach a monitor, and you have to be prepared to intubate. While you are prioritizing to intubate, you can pause the chest compression. If intubation delayed, you can consider a supraglottic device and connection of the ventilator with a filter when possible. And the CPR will be the same. If you have a mechanical device, you can consider mechanical compression. So let's see now in-hospital cardiac arrest specific considerations. So the first one is pre-arrest. So you have to address advanced care directives and goal of care as we discussed earlier. Close monitoring for signs and symptoms of clinical deterioration to minimize the need for emergent intubation. If the patient is at risk for cardiac arrest, consider proactively moving the patient to a negative pressure room or unit if available. Then that room should be closed when possible to prevent airborne contamination of adjacent indoor space. If the patient or cardiac arrest is intubated, consider leaving the patient on a mechanical ventilator and adjust the ventilator setting to allow for asynchronous ventilation. So in neonates, newborns, you can allow chest compression as the same as a ventilation. But how can you adjust the ventilator setting to allow asynchronous ventilation? So the ventilating setting should be with a FAO to 100%, and you can change the mode to pressure control to assist control and limit the pressure as needed to generate adequate chest rise with a proper ideal body weight, tidal volume. So this could be 6 ml per kg ideal body weight. And the next one is make the trigger off, adjust the respiratory rate to 10 per minute for adults and pediatrics, 30 per minute for neonates. Assess the need to adjust the PEEP level according to the lung volume and venous rhythm. And you have to adjust the alarm to prevent alarm fatigue. So the most important here is you have to ensure endotracheal tube or tracheostomy tube and ventilator circuit security to prevent unexplained extubation and detachment. If you have a patient with cardiac arrest and in prone position without an advanced airway, you can attempt to place in the supine position for continued resuscitation. If the patient who are in prone with an advanced airway, you can provide the CPR prone with hands over T7, T10 vertebral bodies. You can also place the defibrillator pads in the anterior or posterior position. So during post-arrest, these patients should have followed with proper infection control practice regarding transport, regarding attachment to the ventilators, and also sending this patient to another facility. So, as a summary, safety always first during resuscitation, safety to the staff, safety to the patient, and early assessment and preparation is always mandatory. Thank you.